بسم الله الرحمن الرحيم. أنا دكتورة أميرة مصطفى Consultant Medical Retina and Imaging Eye Care Eye Center. هتكلم معاكم عن الإيميجينج in AMD. AMD is a chronic progressive disorder of the macula characterized by one or more of the following criteria: presence of at least intermediate sized drusen, RPE abnormalities, reticular pseudodrusen, presence of any of GEO-ATROPHY, exudation with or without neovascularization, or retinal angiomatous proliferation. AMD patients are typically 50 years or older with or without visual symptoms. It is responsible for an estimated 46% of cases of severe visual loss above the age of 40 in the United States, with 90% of cases related to neovascular AMD. AMD can be non-exudative or exudative or neovascular from the clinical point of view. The non-exudative or dry AMD represents 80% of cases and is characterized by presence of drusen, RPE pigmentary changes, and GEO-ATROPHY. The exudative form is characterized by presence of dry disease features associated with basal laminar drusen and pseudovitelliform neurosensory detachment of the macula. The neovascular form is characterized by presence of retinal or choroidal neovascularization. According to the AREDS study group, the AMD severity is graded into 4 groups based on the stereoscopic color fundus photographs, which disease features are evaluated within 2 disc diameters of the center of the macula. The AREDS 1 or no AMD, characterized by presence of very few small-sized hard drusen, less than 5. AREDS 2 or early AMD, characterized by multiple small-sized hard drusen or few intermediate-sized drusen or RPE pigmentary changes. AREDS 3 or intermediate AMD, characterized by presence of numerous intermediate-sized drusen or one larger-sized drusen or presence of incipient GEO-ATROPHY. AREDS 4 or advanced AMD is characterized by presence of GEO-ATROPHY or exudative AMD or neovascular AMD. Also, from this classification, risk factors of disease progression can be summed across both eyes to assess the risk of disease progression over 5 years. The 5-year risk scale is a 5-step scale from 0 to 4, in which one risk factor is assigned for each eye with a larger sized drusen, RPE hyperpigmentation, incipient GEO-ATROPHY, or presence of bilateral intermediate-sized drusen. And 2 risk factors are assigned for patients with advanced AMD in at least one eye. Drusen to be scored only if present within 2 disc diameters of the macular center, as we mentioned, and the risk of progression escalates from total score of 0 up to 4. Score 0 carries 0.5% risk of progression. Score of 1 carries 3% risk of progression. Score of 2 carries 12% risk of progression. Score of 3 carries 25% risk of progression. And score of 4 carries 50% of AMD progression over 5 years. Now we will talk about the clinical features of the AMD. We'll start with drusen. Drusen are the hallmark of the AMD. They are sub-RPE deposits of the extracellular material. Their color ranging from white to pale or bright yellow. Generally, they can be discrete, touching, or confluent. Soft drusen are usually larger or of amorphous appearance compared to hard drusen. So according to the texture, drusen could be hard or soft. Soft drusen usually appear of thickness on clinical examination. According to the size, drusen could be small, intermediate, or large, according to their size compared to the width of a major vein at the optic nerve head margin. Hard drusen appear as small or medium-sized yellowish to white deposits at the proximal membrane level. They are usually bilateral and symmetrical. In infrared and red-free photos, they appear hyperreflective. In autofluorescence photos, drusen appearance is variable according to the changes affecting the overlying RBE. They may show accentuated signal, and sometimes they may show a pattern of central hypoautofluorescence with surrounding halo of hyperautofluorescence. In fluorescein angiography, drusen appear hyperfluorescent in the mid phases of the angiogram because they are hydrophilic deposits, so they will take up the hydrophilic dye, and about 50% of them will stain in late frame. On OCT, hard drusen appear as homogeneous deposits of medium reflectivity between RBE and the underlying proxy membrane. On the other hand, the soft drusen are larger in size, of amorphous soft appearance, and are also hyperreflective in infrared and red-free photos. In autofluorescence, they show accentuated signal due to accumulation of photoreceptor shed outer segments between deceased RBE and the proxy membrane. In fluorescein angiography, soft drusen appear as hyperfluorescent subretinal deposits in mid-frames of mild overlying pooling of the dye lately. In OCT, they appear as dome-shaped, discrete or confluent hyperreflective deposits between RBE and the proxy membrane. Other special types of drusen include refractile drusen, which are chronic drusen that appear as refractile bright yellow deposits of calcification or mineralization. In OCT, fine sub-RBE hyperreflective lipid deposits are seen arranged in stacks called the onion ring sign, and they represent an area of future atrophy. Another special form of drusen is the basal laminar drusen or cuticular drusen. This form of drusen is common in females aged 40 to 60 years. They appear as numerous, uniform, round, densely packed yellowish-white sub-RBE deposits. In autofluorescence, they are hypoautofluorescent of hyperautofluorescent borders. In fluorescein angiography, they appear as densely packed, fine hyperfluorescent subretinal deposits of Milky Way or starry sky appearance, while in OCT, they give the saw teeth appearance, and they carry the risk of having large drusen in the future or formation of neovascularization or acquired vitelliform lesions. Another form of special drusens is reticular pseudodrusen. Reticular pseudodrusen appear as subretinal yellowish interlacing network of lipid deposits that start at the upper temporal macula. They can be seen with any stage of AMD, and they carry high risk of type 2 neovascularization in the future. They are better seen in multicolor and near infrared pictures as donut lesions. We can see them also clearly in blue reflectance or red-free pictures and in autofluorescence photos. Their pattern doesn't fluoresce in fluorescein angiography, so they appear dark, and in OCT they appear as material deposition between RBE and overlying neurosensory retina. Sometimes they appear as projecting into the overlying retina. The second of the features of the AMD is the RBE detachments or PEDs. RBE detachments or PEDs means separation of RBE from the underlying proxy membrane. It could be non-neovascular or neovascular. Four major types of PEDs are described, namely drusenoid PEDs, serous PEDs, vascularized PEDs, and hemorrhagic PEDs. Drusenoid PEDs is a high-risk form of non-neovascular AMD. Its size is about 350 microns or more. They appear as large, confluent, yellowish-white, drusen-like deposits of faint early hyperfluorescence in fluorescein angiogram, with or without pooling or staining in late frames. On OCT, they appear dome-shaped, with or without apical hyperreflective deposits. Sometimes they may show vitelliform deposition, denoting malfunctioning RPE. Serous PEDs, on the other hand, are well demarcated, usually yellowish RPE elevation. It's not pathognomonic for AMD. It appears in only 1% of cases, so presence of drusen is a must. Early intense hyperfluorescence and late overlying pooling of the dye is evident in fluorescein angiography, while in OCT it appears as high arched PED associated with mild overlying subretinal fluid collection. Vascularized pigment epithelial detachments, or type 1 neovascularization according to GUS. It originates from the choroid into the sub-RPE space with accumulation of overlying subretinal fluid. It appears as an ill-defined irregular RPE elevation with or without serohemorrhagic neurosensory attachment in fundus photographs. In fluorescein angiography, it appears as early ill-defined hypofluorescent lesion. In mid-phases, it takes speckled hyperfluorescent appearance for the elevated RPE surface. In late frames, it becomes more defined with overlying subretinal pooling of the dye. Another example of vascularized pigment epithelial detachment. In OCT scans, it appears as an irregular elevation of the RPE associated with overlying cystic edema with or without subretinal fluid, with or without sub-RPE fluid. Vascularized pigment epithelial detachments, if hemorrhagic, vascularized pigment epithelial detachments, if hemorrhagic, appears as areas of blocked choroidal and or retinal fluorescence by associated blood in fluorescein angiography. Sometimes may be associated with sub-RPE, subretinal or breakthrough vitreous hemorrhage. In OCT, we have irregular RPE elevation associated with overlying hyperreflective subretinal blood as well as clear subretinal fluid. This is another example of hemorrhagic pigment epithelial detachment, and we can see the hyperreflective subretinal blood in OCT scans in association also with clear fluid, and the blocked fluorescence of the retina and the choroid corresponding to the subretinal hemorrhage seen in fundus photos. Another feature of the AMD disease spectrum is the presence of subretinal neovascular membranes. Subretinal neovascular membranes are the classic form or GUS type 2 neovascularization. It appears as subretinal yellowish-green neovascular membrane with or without retinal edema, exudation, subretinal fluid, or hemorrhage. In fluorescein angiography, it is characterized by early hyperfluorescence of lacy filling pattern with increasing overlying leakage along the phases of the angiogram with or without late subretinal pooling of the dye if subretinal fluid is present, or areas of blocked fluorescence around corresponding to blood or exudation. On OCT, subretinal neovascular membranes appears as hyperreflective subretinal lesions associated with overlying edema, subretinal fluid, exudates, or subretinal blood accordingly. The RAB lesions or GUS type 3 neovascular AMD are subretinal neovascular membrane associated with diving retinal vessels at 90 degrees angle, representing the site of retinochoroidal anastomosis. Whether it starts below the RPE or below the retina, it's still controversial, but all we know it's a sort of retinochoroidal anastomosis. Another example of RAB lesions. The DISCIFORM scars represent the age stage of neovascular AMD. It represents presence of fibroglial tissue proliferation along CNV tracks. Appear as yellowish-white subretinal fibrotic lesions with or without pigmentary changes. Sometimes subretinal fluid or exudation may present. New neovascularizations may arise at its margins, usually associated with poor vision. In infrared and red-free photos, they appear as hyperreflective subretinal lesion, while in autofluorescence photos, they appear as hypoautofluorescent lesions with hyperautofluorescent margins and the halo of altered autofluorescent signal around from the deceased RBE. In fluorescein angiography, DISCIFORM scars shows early hyperfluorescence and late staining with or without leakage or marginal pooling according to the remaining activity. Halo of dense mottling hyperfluorescence of perilesional deceased RPE is also present. In OCT scans, DISCIFORM scars appear as subretinal lesions of diffuse hyperreflectivity associated with extensive overlying loss of outer retinal layers and underlying RBE thinning. Now with the EXUDATIVE AMD, we mentioned EXUDATIVE AMD in the clinical classification. It is characterized by presence of dry disease form such as DRUSEN, RPE pigmentary changes, and RPE atrophy associated with basal laminar drusen and the pseudovitelliform detachment of the macular area. Here, EXUDATIVE AMD, as we mentioned, it has no neovascularization. Vitelliform deposits appear as subretinal yellow deposition of markedly accentuated signal in autofluorescence photos and the marked overlying pooling of the dye in fluorescein angiography. In OCT, we see dense hyperreflective vitelliform material between the RBE and the overlying intact neurosensory retina with or without underlying basal laminar drusen. Vitelliform matter usually resorbs over time with subsequent formation of GEO-ATROPHY. Rarely, CNV may form in these cases, but again it's rare, and the GEO-ATROPHY is the most common natural course of these cases. GEO-ATROPHY, according to the ARM study group, GEO-ATROPHY is a sharp demarcated, rounded or oval shaped area of at least 175 microns involving foveal zone. It can be hypo or depigmented with readily visible underlying choroidal vessels. GEO-ATROPHY forms after regression of large sized drusen, pigment epithelial detachment, or pseudo-vitelliform macular detachment. In fundus photographs, GEO-ATROPHY appears as white, well-defined areas of RBE atrophy that appears hyperreflective in infrared and red-free photos and shows reduced autofluorescent signal in blood autofluorescence photos due to absence of RBE cells or presence of degenerated RBE cells with reduced lipofuscin content. Incipient GEO-ATROPHY, as we mentioned, means presence of areas of RBE atrophy not fulfilling the ARM criteria, representing a pre-GA stage, like the photos in the lower row. Incipient GA or non-GA at presentation means formation of GA involving fixation within 2.5 years. In fluorescein angiography, GEO-ATROPHY areas appear as well-defined hyperfluorescent RPE window defects that stain markedly in late frames. Sometimes the pre-lesional area of mottling hyperfluorescence of disease RPE is present. In OCT scans, segmental RPE atrophy with overlying outer retinal loss of variable degree, sometimes up to the outer plexiform layer level, is found with accentuated underlying choroidal signal. Once geographic atrophy has developed, its growth can be monitored by color fundus photographs or better by fundus autofluorescence images. And the annual linear growth rate can be estimated at about 2 square millimeters per year. Factors affecting geoatrophy progression include presence of drusen and differs according to their number, distribution, and regression form, its size in baseline, presence of incipient geoatrophy, or presence of geoatrophy in the other eye. The last part of this section will brief the OCT signs or biomarkers of both activity and atrophy in patients with AMD. In neovascular AMD, presence of retinal edema, subretinal fluid, exudation, subretinal blood are all signs of activity, while in non-neovascular or dry AMD, formation of new neovascularization at the edge of geoatrophy area denotes activity as well. The OCT biomarkers of atrophy, on the other hand, represent the advanced disease process, and they can be seen in any form of advanced AMD. They include outer retinal tubulations or ORTs, outer retinal corrugations or ORCs, age-related choroidal atrophy, hyporeflective atrophic wedges, and the splitting of band 4. Outer retinal tubulations are thick hyperreflective band surrounding a branching hyporeflective cavity, all within the outer nuclear layer. They can be rounded or oval or oblong in shape. They contain degenerated photoreceptors and enveloping Mueller cells. The outer retinal corrugations appear as curvilinear, undulating, hyperreflective material above the Bruch's membrane that occurs within areas of macular atrophy. They represent remnants of regressing drusen and basal laminar deposits. The hyperreflective atrophic wedges are the OCT biomarker number 3. They represent tracts of degenerated outer plexiform layer at the margins of GEA areas. Their base usually lie on the Bruch's membrane, and the apex is pointing towards the inner limit of the outer plexiform layer, adjacent to the margin between the atrophic retina and the preserved retina. Hyporeflective atrophic wedges are thought to be related to axonal swelling of outer nuclear layer cells. The biomarker number 4 is leptochoroid or age-related choroidal atrophy. It means the presence of accelerated global choroidal thinning with rarefaction of choroidal vessels and the loss of choroidal pigmentation, usually seen in patients with reticular pseudodrusen, and its presence may carry the risk of glaucoma in such patients. Splitting of band 4, which is the hyperreflective Bruch's membrane RPE band. Splitting of these bands is a sure sign of atrophy in AMD patients. In the last part of this talk, I will give you a hint on the OCT angiography. The OCTA allows blood flow detection based on motion contrast derived from variation in signal amplitude over time within a voxel due to movement of blood cells. It has some advantages over fluorescein angiography, which are being non-invasive, depth resolved, allows detailed assessment of retinal and choroidal vasculature, characterization of neovascularization, and the detection of non-exudative type 1 neovascularization. The image analysis in OCTA depends on detection of the source of motions and the artifacts. The source of motion in OCTA is the bulk motion related to the movement of the eye and the head of the patient, and the movement related to the circulating blood flow. The artifacts are usually related to positioning errors, projection artifacts, or segmentation errors. OCTA images examines the retina, with the ILM is the inner contour and the RPE is the outer contour. It allows visualization of superficial capillary layer, deep capillary layer, and the avascular layer. The choroidal slabs follows the RBE fit line and the choriocapillaris, and it allows visualization of the choriocapillaris very well. There are several criteria, however debatable, of neovascular lesions detected by the OCTA, depending on the shape, morphology, structure, presence of anastomosis, loops, and the perilesional hypointense halos. However, it has its limitations because it provides no information on the vascular wall integrity comparable to the leakage detected in fluorescein angiography, its acquisition time a bit long, the field it covers, the presence of motion artifacts, and retinal vascular projection artifacts. For now, it is just recommended for AMD-related research purposes. My take-home message today: DRUSEN is the hallmark of AMD. Multimodal imaging approach is crucial for AMD diagnosis, grading, and management via identification of risk factors of disease progression, biomarkers of disease activity, and biomarkers of atrophy. Each modality has its strengths and weakness, and the multimodal imaging may be a sensible approach to obtain the most reliable detection and measurement of disease process. Certain disease features, such as cuticular drusen, pseudoreticular drusen, should not be overlooked. According to the CAM study groups, we have the imaging protocols in clinical studies in patients with advanced AMD. For patients with dry AMD, you need baseline and follow-up color fundus photographs, infrared, autofluorescence, and OCT targeting the areas of GEO-ATROPHY, and fluorescein angiography is recommended only if secondary neovascularization is suspected. For patients with wet AMD, you need baseline and follow-up autofluorescence and fluorescein angiography every 6 months, multicolor infrared and autofluorescence in association with fluorescein angiography visits, OCT at baseline and with each follow-up. OCTA is optional. These are tables for the recommendations of use of multimodal imaging in patients with non-neovascular AMD and patients with neovascular AMD. Thank you and good luck.